Yeah, it's okay, but I believe there's some lag because whatever I'm speaking right now will be visible to me after a while. 30-second delay. It's a bit too much. Should we kind of just squeeze it a bit more? And how do I talk to students there? Yeah, it's okay, but will the top end be visible to the students? I'm not getting the chat window there. Here, अच्छा इस पे खोल देते हैं लो जी, ये भी आपके लिए ही है, बट इस पे लिंक देखना पड़ेगा। एक मिनट बंद करिए। ना ये सब नहीं चाहिए कुछ। नाई को ज्यादा पैसे देने पड़ने अगली बार से। ये तो सरकार, ठीक है, तो सरकार, अच्छा इसका आवाज बंद करना पड़ेगा, इसकी आवाज बंद करना पड़ेगा। आ गया मेरे पास था ब्रो। भाई चैट तो फिर नहीं है। अच्छा लेफ्ट साइड पे, हाँ ठीक है इसको, हाँ ये ठीक है, ये ठीक है, ये ठीक है। हाँ सही में। Right, okay. So because you people are running short of time, I just saw a status update that probably you are left with just 15 days. I mean 16 days, but last वाला दिन तो फिर ऐसे वेस्ट ही जाता है, right? भाई एसी नहीं चल रहा, एक तो मैं पहले से इतना हॉट हूँ, है एसी खराब हो गया। चलो, this is okay. Okay, right. So you people are left with very little time. I believe, I just read a status update that you're left with just 16 days, and I believe not 16, it's going to be 14 or 15 days because एक दो दिन तो टेंशन में ही निकल जाएंगे, right? So what I've done is I've kept some of the questions. Online batch guys, maybe we have discussed around 10-15 of the questions which I'll be showing here. I believe we have discussed at least 10-15 questions already. Right now, it was supposed to be a mix and match of surgery and ortho, but I've kept around 90-95% surgery and only 3-4-5 questions of ortho. Right, most of the questions are of surgery only. Yeah, it's going to be all questions only. It's going to be all questions only. Fine, and I've come with a target that I won't take more than 2 hours of yours. More than 2 hours of yours I won't take, and I'll try to cover the important topics there. Right. Now, without wasting any time, let's continue. And meanwhile, if you have your queries, the chat window is open in front of me and you can send your queries. So, Rahul ji, no, answer is not B. Arsh ji, answer is not B. So, 42-year-old female underwent screening mammography. Mammography starts at 40 years of age and it has to be done annually, which showed evidence of fine calcification in her left breast. Okay, fine calcification in her left breast is indicative of something malignant. Is indicative of something malignant. I'll share the PDF. You don't have to worry about it. I'll share the PDF. These are my questions. I have formed them on my own. Fine, so I can easily share with you guys. Right. So stereotactic. The word stereotactic means it is guided by mammography. Guided by mammography. So mammography is going to tell you where you need to put your needle. Where you need to put your needle. Now, if you guys would allow me, I would like to keep on asking some of the questions in between. For example, you please tell me which of the following needles would you prefer for breast biopsy? let's say it's going to be 23 gauge needle. Fine. It's going to be 21 gauge needle. It's going to be 18 gauge needle, or it's going to be 16 gauge needle. Which of the following needle would you prefer for breast biopsy? Okay. So this certainly is preferred for FNAC. This needle is certainly preferred for FNAC. This is the preferred needle for breast biopsy. 16 gauge needle is the preferred needle for breast biopsy. This 23 gauge needle is for FNAC, fine needle aspiration cytology. The word is fine needle aspiration cytology, right? Okay, so this shows the presence of ductal carcinoma in situ with comedo features. You see, this carcinoma, this ductal carcinoma, which has got comedo feature. Now, this is supposed to be slightly aggressive. Right? Now, so that is why you have to be, slightly overboard. Otherwise, what you can simply do is you can do the local excision. But you see here you have to go slightly overboard. But even then, you see, if we do, just a minute. So, if we do modified radical mastectomy and radiotherapy, so we believe that it will be too much. It will be too much of surgery. Fine. Such kind of surgery is not required. Remember, what is the most common complication with breast conservation? What is the most common complication with modified radical mastectomy? The most common complication with modified radical mastectomy would be seroma formation. Fine. Then there are multiple nerve injuries. Remember, intercostobrachial nerve injury, accessory nerve injury. There are so many nerve injuries. There are many complications with modified radical mastectomy. So we don't want to do this. Modified radical mastectomy. Let me pick up something. Let me pick up a page, and I'll share this page with you also. Of course, after I get permission, I get go ahead from Ashish sir. Only then I'll go ahead with sharing this page. So, just give me a minute. Right. Now, so you see, what do we remove in modified radical mastectomy? We remove breast, including nipple areola complex, including level 1, level 2 lymph nodes in the ocean clause. We remove level 1, level 2, level 3 lymph nodes in the other type of mastectomies, the scanlon and the Pattage mastectomy. Fine. So this is going to be a disastrous surgery. Your patient will experience lymphedema after the surgery. We don't want such kind of complication. Comedo features means your patient is developing necrosis. Of the tumor. Tumor is so rapidly growing that a part of the tumor is getting necrosed. Comedo is generally with necrosis. That means the tumor is rapidly growing. Right? So modified radical mastectomy is a no. Fine. We won't be doing modified radical mastectomy. Chemotherapy. Remember, always remember, and don't forget ever, that if we do radiotherapy, that is for local control of recurrence. If we do chemotherapy is for distant metastasis. So we won't be doing chemotherapy here, because distant metastasis, they are very rare. In ductal carcinoma in situ. Fine. So I believe this option is also gone. So the only logical treatment that remains is breast conservation surgery and radiotherapy. conservation surgery and radiotherapy. Fine. Breast conservation surgery. Now, what can they ask here? What can they ask here? They can ask you about contraindications of breast conservation surgery. Breast conservation surgery, and we have absolute contraindication. 4 of the absolute contraindication. First is polycentric. Polycentric means 2 tumor in different quadrants. Fine. Second is previous history of radiotherapy. Third is pregnancy. Third is pregnancy. Polycentric, previous history of radiotherapy. And the next is positive tumor margins. Now remember one thing, that polyfocal tumors, like 2 tumors, 2 or more than 2 tumors in the same quadrant. Now this is going to be a relative contraindication. This is going to be a relative contraindication. Relative contraindication. Yeah, so Dr. Shak, this you see large tumor in the small breast. This again is a relative contraindication. You see centrally located tumor, like tumor located near nipple areola complex. This again is going to be, a relative contraindication. What I believe is that you must be remembering these 4 contraindications, because these are absolute contraindication. These are absolute contraindications. Polycentric tumor, previous history of radiotherapy, pregnancy, and positive tumor margins. Positive tumor margins, right? Yeah. Yes. Radiotherapy is compulsory. Radiotherapy is compulsory because, you are just leaving some of the tumor tissue inside. CI means contraindications. Contraindications. More lobe. See, this is the one. This is relative contraindication. 2 tumors are present in 1 lobe. Here, the tumor, either they are present in the separate lobes or they are more than 5 centimeter apart. They are more than 5 centimeter apart. Right? So you see, this is how we are done with the first question. We are done with the first question there, right? So that is what I'm telling you, that this is going to be our speed, and maybe we can cover some of the question in even lesser time, because I'm not in a mood to take too much of your time. I'll try to convey the information which I have with me in as less time as possible. Ortho bhi kara denge ji, ortho bhi kara denge. Yes. डॉक्टर हार्दिक सोलंकी जी डेफिनेटली करा देंगे. पहले जरा इसका आंसर दे दो प्लीज. इसका आंसर हार्दिक सोलंकी जी देंगे प्लीज. So we are talking about the clinic of Dr. Hardik Solanki. He is so lucky that 3 females visited his clinic today. We'll have to do. Yeah, images too will be there. I'll take time. Yes, definitely. Dr. Hardik, please try to answer this question, and maybe everyone else can also try to answer this question. So on a particular day, 3 females attended surgery OPD. Oh. Maybe I was a bit too drunk while I was, typing this. So OPD. Maybe, I was a bit too drunk when I was typing this. So, first female, Mrs. X, Mrs. The female is married. A 30-year-old mother of 2, and she is not even nulliparous. She is a heavy smoker. Tell me, is she at increased risk of developing breast cancer? Is she at risk of developing breast cancer? Yeah, definitely. I am so glad that you got the right answer. Many of you got the right answer. Wow. So you see, smokers, they are not at risk of being detected with cancer. Yes. I'm so glad. It's not associated with smoking, not associated with smoking. Fine. Now, Mrs. Y, 38-year-old suffering from fibroadenosis with history of multiple breast biopsy. She is at the risk of developing breast cancer. See, biopsy itself is not a risk factor. Biopsy itself is not a risk factor. But the thing is that she is so vigilant about her breast that even if there are changes, that will be detected very early. That will be detected very early. So that is the point which I want to convey, this point, that multiple breast biopsy, even if they are benign, the female is at the risk of being detected with a breast cancer, Fine. Now, Mrs. Z, a 41-year-old mother of three with incidental finding of a radial scar. Yes. What about the radial scar? You guys have to make me laugh. You guys have to make me laugh. You guys have to make me smile. Score 200 and above. And all day, night, the night of your result, I will be the one who will be smiling the most. बॉटल अपन ने खत्म नहीं होने देनी, हंसते रहना उस दिन बस. Now, you see here, we have two things. One is radial scar. Now, radial scar can be seen on pathological slides, can be seen on mammography images, Now, radial scar is generally less than 1 centimeter in size. Fine. Now, if it is more than 1 centimeter in size, this will be called as complex sclerosing lesion. So, there is increased risk of breast cancer. Definitely. This will be enough for June FMG, I believe. I mean, at least I've tried to cover as much topics as possible. Buddy, Glenlevy, Glenfiddich, you just tell me the choice. Score 200 and plus and convey the brand of your choice on my phone number. I will be the one who will be serving you if you're into it already. So, increased risk of breast cancer. So, I believe here, who are at the risk? So, this female and this female, she is not at the risk. The Mrs. X, she is not at the risk. So, this is going to be the answer. Yes. Do score. Right. I told you we won't be wasting too much of time. Okay, buddy, blue label done from my side. But in that case, you'll have to score 250 and above. 50 marks to extra बनते हैं blue label के. No. Don't even think that only B. Radial scar is a strong predictor of malignancy. Female will come with a lump. You get the mammography done. It shows radiating, stellate calcification. So this is a strong predictor of malignancy. Okay, I'll get it from Chandigarh. No. This is not going to be Paget disease. Remember, this radial scar is a totally different pathology. Patient will come with a lump. You get the mammography done. And this is the type of calcification which you will see, radiating into all direction. Same thing you will see on the pathology. File. Yes. Even if it is less than 1 centimeter, see this. Radial scar, even if it is less than 1 centimeter in size, this is going to be a risk factor, Now let me just show you what is radial scar actually. Now you see, if I just keep on opening my PPTs, that is going to consume a lot of space there, consume a lot of time there, and time we don't have. Now see, this is a radial scar, Can you see it is moving in all directions? Radial scar. Let me show you the radial scar on mammography. Now, can you see this star-like thing? Scar-like thing. See, star-like thing. Differential diagnosis. This usually is an incidental finding. So if they show you any mammography image like this or any histopathological image like this is a radial scar like the tire of a cycle, Still scar. It could be present. See, buddy, Dr. Muhammad Thala, I hope I'm pronouncing your name correctly. But we are not talking about the radial scar. Radial scar at microscopic level we are talking about. We are not talking about the scar which will be visible to your naked eyes. No, we are not talking about that scar. We are talking about the scar which is seen at microscopic level. That's a totally different pathology. Right? I understand, buddy. I understand. I'll try to keep it short. Don't worry. So, 42-year-old female underwent screening mammography, which shows an area of calcification. She underwent, probably I was under the influence of something when I was typing these things. So, she underwent a biopsy which shows presence of lobular carcinoma in situ. Choose the correct answer. Choose the correct answer there. Yes, you have to choose the correct answer. Now you see your patient is suffering from lobular carcinoma in situ. So after 8th American Joint Committee of Cancer revision, remember this is now considered a benign disease with a potential for malignancy. Right? Benign disease with a potential for malignancy. So only and only if your patient gets detected, let me just change it. So you see, if your patient gets lobular carcinoma in situ, only meaning of this diagnosis is that she is at increased risk of developing breast cancer. One thing more, whatever answers I'm giving, they're strictly according to Love and Bailey. Fine, they're strictly according to Love and Bailey. So whatever is written in Love and Bailey, I'm following that. Risk of developing breast cancer. So if a female is at the increased risk of developing breast cancer, what do? We just increase the surveillance. So she will be asked to visit the clinic every 6 months, and as always she will be undergoing mammography every 1 year. Every year she'll be undergoing mammography. Now, if she's not satisfied, what can we advise her? We can advise her bilateral mastectomy, and this mastectomy will be simple mastectomy. She is at the risk of developing cancer. She has not developed cancer. She is just at the risk. Remember, lobular carcinoma in situ is a benign disease. Please keep that thing in your mind. Lobular carcinoma in situ is no longer considered a cancer. No longer it is considered a cancer. Fine. No longer it is considered a cancer. Fine. Or we can give our patient tamoxifen. Fine. We can give our patient tamoxifen. That is what is required. That is what it is required. Now let's examine the options. Modified radical mastectomy, you see, is a cancer surgery. So we will not advise her to undergo modified radical mastectomy. Fine, we will not advise her to undergo modified radical mastectomy. The risk of lymph node spread in a benign disease is non-existent. It is not there. So this option is also incorrect. Now this option is going to be our second choice. The preferred treatment, according to the literature, according to the books, is going to be 6 monthly clinical breast examination and annual mammography. Fine. So we are going to advise our female patient 6 monthly clinical breast examination and annual mammography. If she is not satisfied, what will we advise her? We will advise her bilateral simple mastectomy, because the cancer can be present in right breast, cancer can be present in left breast, cancer could be present in any of the breast in case of lobular carcinoma in situ. Fine. Now, the bottom line is lobular carcinoma is a benign disease. Lobular carcinoma means increased risk of cancer. Right? Yes. A healthy 28-year-old woman with no previous pregnancies noted a breast mass while attempting to conceive. She was trying to get pregnant. She has no family history of any malignancy. That means she was supposed to be a low-risk candidate. After clinical examination in surgery OPD, she underwent an ultrasound-guided fine needle biopsy as advised. Now, when the FNAC was done, she was found to harbor invasive ductal carcinoma. Oh my God. Fine. So this is going to be estrogen and progesterone receptor negative. Few days after the biopsy result, she found out that she was pregnant. She was offered termination of pregnancy, but she declined. Preferred treatment now is, yes. So you see, we cannot do chemotherapy in the first trimester, whether it is methotrexate or it is non-methotrexate. Fine, we are not going to do this. This is the preferred treatment. We will perform modified radical mastectomy as early as possible. And then we can start with the non-methotrexate based chemotherapy in the second trimester. Breast conservation and radiotherapy. So radiotherapy cannot be done in pregnancy. Simple mastectomy and sentinel lymph node biopsy, no, it has to be modified radical mastectomy. Always it has to be modified radical mastectomy. यार वो क्लास प्लस अपना बंद करना पड़ेगा शायद आपको, उसके कारण थोड़ा सा। ओके, रिमेंबर, फर्स्ट ट्राइमेस्टर, सेकेंड ट्राइमेस्टर, third trimester, surgery can be done in any trimester. Chemotherapy cannot be done in the first trimester. Radiotherapy, hormone therapy cannot be done in any of the trimester, cannot be done in any of the trimester. You see, breast conservation surgery can be done late in pregnancy, can be done late in pregnancy. You see, she is about to deliver a baby, and at that time she has been diagnosed with breast cancer. You do the breast conservation surgery, and then you can always do radiotherapy after delivery. You can do radiotherapy after delivery. So in that case, radiotherapy can be done after delivery. अतुल्य जी स्क्रीन फ्लिकर कर रही है थोड़ी सी, स्क्रीन थोड़ी सी फ्लिकर कर रही है। ये मेरी स्क्रीन भी फ्लिकर कर रही है। Nevertheless, please read this question. You guys continue, please. इसमें सब ठीक है। तो भैया किसी को बोलेंगे मुझे पानी की बोतल दे देगा प्लीज। Yes, you read this question. Don't worry about the screen. You just read this question. Anything else. So 2 years after undergoing an exploratory laparotomy for a gunshot injury, a 41-year-old forest guard. So you have to, you see, highlight the catchword. History of undergoing exploratory laparotomy. Thank you. 41-year-old forest guard presented to surgical emergency with complaint of pain, abdomen, vomiting, abdominal distension. Read this. Those who are saying answer as one, please read that your patient is having abdominal distension. Your patient is having abdominal distension. Further, he also complains of not having passed stools and flatus since morning. X-ray abdomen was done, which returned the following picture. What do you get to see in the image first of all? You get to see valvulae conniventis, which indicates jejunal obstruction, which indicates jejunal obstruction, jejunal obstruction. Second thing, remember, you don't see any gas here. So you see valvulae conniventis. This, what you see on your screen is valvulae conniventis. बड़ी डिस्प्ले गायब हो गया वहां से। अच्छा, what you get to see on your screen is valvulae conniventis. Now those, let's see each of the option one by one. Why it is not a proximal intestinal obstruction? Why it is not a proximal intestinal obstruction? Remember, please do remember that there is minimal abdominal distension. There is minimal abdominal distension in proximal obstruction. है? हाँ, थोड़ा सा फ्लक्चुएट हुआ है। मिनिमल abdominal distension in proximal obstruction. Remember, हाँ ठीक है। Remember, I hope you can remember that the only clinical feature in duodenal atresia, only clinical feature in duodenal atresia is bilious vomiting. Only clinical feature in duodenal atresia is bilious vomiting. So there is no distension at all. There is no distension at all. Okay. So I believe this proximal is ruled out. Proximal is ruled out. Right. Now, since it is showing valvulae conniventes, this is definitely a jejunal obstruction. Jejunal obstruction is there, right? So this is going to be mid-intestinal obstruction. Mid-intestinal obstruction. What is the cause? Remember, the most common cause of small intestine obstruction is adhesions from a previous surgery. Adhesions from a previous surgery. Triple bubble sign is going to be seen in jejunal atresia in children, not here. Triple bubble sign will be seen in children, newborn will be seen in newborn, right? Achha, one more thing. In small bowel obstruction, gas is seen in center. In large bowel, gas is seen in the periphery. Nobody. No. Why tough? You see one thing there. Do you see any gas in the periphery, Dr. Bhavesh? No, Dr. Hypersomniac Medico. Do you see any gas in the periphery over here? No. You see all the gas in the center. So that means it is going to be a small intestine obstruction. This is going to be a small intestine obstruction. Proximal intestine, it is not, because you see there is minimal distension in proximal obstruction. Distal intestine, it is not, because what do you get to see then? You get to see characterless loops of ileum, but you are seeing some characters there. Remember, there's an arrow also over there, valvulae conniventes. So most likely this is a mid-intestinal obstruction. This is not a colonic obstruction. Why? Because you don't see any gas in the periphery. I'll definitely share this PDF. I have not copied it from any book. I've made my own questions there. Fine. So I can very, very easily share this PDF. You don't have to worry about it. And today, fortunately, my boy Rahul is not there and Yogesh. Otherwise, they would have focused on this instead of the question. Distal obstruction will be featureless. Thank you, buddy. Rahul hai? Oh my God. Okay, see this. Oh, Rahul hai wahin pe. Okay, please answer this question. 40-year-old presented to surgery OPD with complaint of a neck swelling with limited mobility. An angiography was performed which returned the following picture. Pick the correct statement. Okay, I'm so glad. Now, please tell me what is a diagnosis. That's a typical radiological image. What is the diagnosis there? No. First, tell me what is the diagnosis. No. Yes, this is a carotid body tumor. Dr. Yuvraj got it right. This is a carotid body tumor. Now, This is an extremely vascular tumor. It will get blood supply from external carotid artery. The tumor itself is seen at carotid artery bifurcation, carotid artery bifurcation. It is not a malignant tumor. Risk of malignancy is less than 10%. Now, if this is not a malignant tumor, it is not going to be metastatic. Yes, sometimes it may secrete catecholamines. Sometimes it may secrete catecholamines. It may secrete catecholamines. So this is the only right answer. Now what you get to see on the screen is Liar sign, which is usually seen on angiography, which may be seen on CT angiography also, CT angiography. The only treatment here is observation. We just keep on observing the tumor. We just keep on observing the tumor. That it's not eroding into the artery, it's not getting malignant. That is the only thing which we do. Right? The tumor is so vascular, it may cause ferocious bleeding. So we don't prefer doing it, we don't prefer removing it. Right? Not wasting much of your time. Yes, Liar sign, Dr. Rahul, got it right. I'm so glad those who are answering C over here that you got it right. You know, that's actually heartening for me to know. You have read surgery from any teacher, but that's a moment of pride for us that you are, answering the question correctly. Actually glad. Now, please answer this question. 6-year-old girl was rushed to emergency department after she complained of difficulty in breathing. On examination, a swelling was noticed on the posterior aspect of her tongue. The likely diagnosis is Sumit ji, so glad to see you. Okay, was rushed to emergency department after she complained of difficulty in breathing. On examination, a swelling was noticed on the posterior aspect of her tongue. Likely diagnosis. It is not angioneurotic edema because in this case, entire tongue would have been swollen. It is not hemangioma. It is not hemangioma because in this case, it would have presented with bleeding. It would have presented with bleeding. It is not dermoid cyst. It is not dermoid cyst because generally this is seen at the lines of embryonic fusion, and intraoral is extremely rare. Intraoral is extremely rare. So this in all probabilities is a lingual thyroid, Now those of you who have read with us, please tell me what is the most common clinical feature of a lingual thyroid? What is the most common clinical feature of a lingual thyroid? It is an ectopic thyroid, certainly it is an ectopic thyroid. But what is the most common clinical feature of lingual thyroid? So most common clinical feature of lingual thyroid is going to be hypothyroidism. That is going to be the most common clinical feature, hypothyroidism. Fine. The preferred treatment is excision. You see, the other rare clinical feature, it may cause dysphagia, it may cause dyspnea, it may cause sleep disturbances, speech disturbances. Why it is an emergency now? Because you see, okay, very good. So doctor, let me just answer Dr. Sarthak Goyal's question. Remember, Dr. Sarthak Goyal, what is the problem with lingual thyroid? Lingual thyroid most common clinical feature is hypothyroidism. That means low T3, T4. That means high TSH, there will be too much stimulation. The gland will become big and it will start it will cause obstruction of the airway. It will cause obstruction of the airway. She must have had symptoms, but now it has become too big due to continuous stimulation that it has started to obstruct her airway. Started to obstruct her airway. It is a congenital condition, but this day it has become so big that for the first time it has started to compress her airway. Started to compress her airway. Fine. This is the first day when this lingual thyroid started to compress her airway and she was rushed to the emergency department immediately. 6-year-old boy is brought to surgery OPD by his parents with 5 months history of a painless, slow-growing mass in the neck, left of the midline, left of the midline. Ultrasound was done, which returned the following picture, Preferred treatment is, first of all, please tell me what is this. Now, what I have done is I have, highlighted this catchword, slightly left of the midline, no. First of all, please tell me, one or two, that what is the diagnosis there? What is the diagnosis there? Yes, Dr. Shala Aftab. D is the right answer. D is the right answer. Now you see here, because it is appearing black, so that means it is a cyst. What type of cyst? It is a thyroglossal duct cyst. No, this is not a cystic hygroma. Now, thyroglossal duct cyst. Fine. Now, this is a midline swelling present slightly towards left. Most common location, remember, is subhyoid. Most common location is subhyoid. Now, this swelling moves with protrusion of tongue, moves with swallowing. Now remember, what is the treatment? Treatment is cyst trunk operation. What is cyst trunk operation? If you read it correctly, cyst trunk operation is en bloc excision of thyroglossal tract, the cyst, and middle 1/3 of the hyoid bone. Cyst trunk operation. So en bloc excision is going to be the right answer. Aspiration we don't do, sclerotherapy we don't do, excision we don't do, because after excision there will definitely be recurrence. Less than 10 years of age, the age. If the infection is present, we will just give antibiotics and then we will do the same surgery, cyst trunk operation only. No. Okay. So first you'll have to make a diagnosis here. Then you will have to tell me which treatment method is to be avoided. Now, how can you make the diagnosis? See, the trachea is deviated. The superior vena cava is compressed. Dr. Rajlakshmi, very good answer, but please tell me what is the condition? What is this patient suffering from? Remember, what is this? You want to give the answer there? So you see here, your patient is suffering from retrosternal goiter. Your patient is suffering from retrosternal goiter. Retrosternal goiter. So your patient here is suffering from अतुल्य जी, वो जो क्लास प्लस आपने डाउनलोड किया था ना, उसको हटा दीजिए, उसके कारण स्क्रीन फ्लिकर कर रही है। आई बिलीव क्लास प्लस की जरूरत तो है नहीं हमें, जो भी आपने वो सॉफ्टवेयर डाउनलोड किया था ना, उसके कारण ही स्क्रीन फ्लिकर कर रही है। गाइस जस्ट गिव मी अ मिनट, वी आर जस्ट डूइंग समथिंग हियर। कीप ये शेयर करनी है बच्चों के साथ। लेट्स व्यू, इसको हटा दीजिए, इसके कारण कर रही है स्क्रीन फ्लिकर, हमें चाहिए तो है नहीं ये, बिकॉज पहले बिल्कुल ठीक चल रहा था, पहले वाली क्लासेस सारी ठीक हुई हैं। बच्चा स्टूडेंट्स आपको हेलो बोल रहा है। है? So you see here in the retrosternal goiter, what do you get to see? Pemberton sign. So when the patient will raise his limbs, there will be, puffiness of the face, flushing of the face, stridor will be there, hoarseness will be there. Fine. Pemberton sign. And remember, the preferred treatment method is surgery. Surgery done through a cervical incision. Surgery done through a cervical incision. We don't use iodine 131 in the management. Iodine 131 is not used because of the proximity of important structures. We don't use iodine 131 in the management. Iodine 131 in the management. Right? Yes. So please tell me the answer to this question. After undergoing thyroid surgery for grave disease, 38-year-old school teacher complains of hoarseness. Laryngoscopy was repeated, which confirmed left side vocal cord to be lying in median position. Likely nerve injured is. Yes, please answer. So, your patient is having unilateral recurrent laryngeal nerve palsy. Unilateral recurrent laryngeal nerve palsy. Remember, if these are the vocal cords, cricothyroid will pull it medially, and cricothyroid is supplied by external laryngeal nerve. Fine. Now, which nerve Recurrent laryngeal nerve will cause abduction because it is paralyzed. So what will happen? The vocal cord will come to lie in the midline. Vocal cord would come to lie in the midline. Yes, 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 Rahulji, you gave the right answer there. Fine. So your patient has left recurrent laryngeal nerve injury. Recurrent laryngeal nerve injury. Yes. A patient was wheeled into surgery emergency with alleged history of sustaining injuries in a brawl. Brawl is like fist fight. Fine. He is conscious, oriented. Blood pressure was found to be 114/70. Pulse rate 96 per minute. He was admitted to monitor input and output, and it was decided to catheterize him. However, blood was noticed oozing out from urethra. Management now includes, first of all, which injury is this? Which injury is this? Bulbar urethra or membranous urethra? So you see this patient of yours has a bulbar urethra injury. In bulbar urethra injury, no Foley catheterization, no Foley's catheterization. We don't even think of it. We don't even do Foley's catheterization. So this is certainly wrong. This is certainly wrong. Abandon urinary catheterization. This is certainly done. This is certainly done. Fine. So what we do is, instead of this, what will be our preferred approach? Our preferred approach would be suprapubic catheterization. Suprapubic catheterization. Single attempt to pass a soft catheter. See, it is clearly written in the Schwartz standard textbook of surgery that if there is membranous urethra injury suspected, membranous urethra injury suspected, then you can do single attempt by a specialized doctor. That means a urologist can give one attempt in membranous urethra injury. In abandoned, abandon means we avoid it. We say we will not do it now. Abandon means we will not do it now. Abandon means we will not do it now. Yes, in membranous urethra injury, you can give one attempt, but only if there is no blood. See, I'll make an algorithm. So you see, bulbar urethra, membranous urethra plus blood at meters. What is going to be the treatment? SPC, suprapubic catheterization. Membranous urethra plus no blood at meters. Single attempt by expert. Single attempt by expert. Fine. See, Dr. Rahul Hitesh Kumar. So you see here, in the membranous urethra injury, generally there would be pelvic fracture. Generally, there would be pelvic fracture. In the bulbar urethra injury, generally there would be kick to the perineum. Generally, there would be saddle injury. there would be saddle injury. So remember, what is the most common cause of urethral trauma? This is iatrogenic. That means done by the doctor himself or herself. Yeah, definitely, buddy. Why not? Bulbar urethra injury. Bulbar urethra, membranous urethra. So bulbar urethra injury, there will be retention, there will be blood at meatus, there would be butterfly hematoma, butterfly hematoma in the perineum. Membranous urethra injury, generally there would be pelvic fracture, there would be pelvic hematoma, there would be pelvic hematoma, there would be retention of urine, and there could be blood at meatus. There could be blood at meatus. Treatment in both is suprapubic catheterization. Treatment in both is suprapubic catheterization. Dr. Sarthak, Dr. Sarthak says that there would be high riding prostate. So high riding prostate, remember, is called as Vermeutin sign. How do you get to see Vermeutin sign? On probing deep, in digital rectal examination, which is not allowed. So we don't have to look for high riding prostate. We don't have to look for high riding prostate. It will be. Dr. Tejkumar ji, that's what I'm saying. We don't have to look for a floating prostate, because you see, Vermeutin sign should not be elicited. That is characteristically recommended by the ATLS, that don't look for Vermeutin sign. Don't poke too deep. Yes, there is a lag of around 30 seconds. What is the management of bulbar urethra injury and no blood at the meatus? See, management of bulbar urethra injury and no blood at the meatus will be retrourethrogram. So this most probably is going to be a partial injury. In that case, we can do Foley's catheterization, and that too single attempt. Fine. So we have to abandon the urinary catheterization. I forgot to remove the answer there. An elderly male has been rescued from a burning building. He was lying unconscious when spotted by the rescue team. His face is blistered, eyelids are swollen, blood pressure is 114, heart rate 90, respiratory rate is very high. Yes. Now, you see here, what are, how can you suspect airway injury? So if there are face, palate and nasal burns, if there is history of being trapped, if there is carbonaceous sputum, if there is singeing of nasal hairs. So what is the treatment if burn injury is suspected? Treatment in this case is early elective intubation. Treatment in this case is early elective intubation. Early elective intubation is going to be the treatment. So here we need to do early elective intubation. That is going to be the answer. Early elective intubation is going to be the answer. Yes, definitely, definitely. Dr. Ganesh Roy, that is the algorithm. अतुल्य जी ये स्क्रीन बंद हो गई. Yes. So a retired college professor, it was like retired college professor. The word professor is missing. Presents with complaints of mild headache and forgetfulness. He is attended by a general practitioner who suspects him to be having evidence of dementia. Evidence of dementia. The patient is sent for neurological assessment. A CT scan is done which reveals the following findings. Yes, please tell me, what is your patient suffering from? Now, you see an acute intracranial hematoma is dense. So it appears white. It appears white on CT scan. It appears white on CT scan. White on CT scan. Fine. So you see here. Secondly, it is generally plano-convex or it is concavo-convex. 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 Right? Now, you see here on both sides it is black. On both sides it is black. Both sides it is black. Right? So that means this is something chronic. This is something chronic. This is something chronic. Right? Let us compare quickly. Let us quickly compare extradural hematoma, subdural hematoma. So extradural hematoma is common in young and mobile. This is common in elderly. Common in elderly. This occurs with significant trauma. This occurs with trivial trauma. Trivial trauma. So in 80%, this is associated with fracture, and generally there is no fracture. Lucid interval, no lucid interval. Fine. Now, here, investigation of choice NCCT, investigation of choice non-contrast CT. Now, this shows biconvex lentiform hematoma. This shows concavo-convex or plano-convex hematoma. Plano-convex hematoma. Now, preferred treatment, craniotomy. Craniotomy. Preferred treatment is burr hole. Preferred treatment is burr hole. Preferred treatment is burr hole. Now, midline shift could be present in chronic cases also. Could be present in chronic cases also. Midline shift has to be significant. It has to be more than 5 millimeter. It has to be more than 5 millimeter to be significant. Dr. Rahul ji, it has to be more than 5 millimeter. So most common vessel, middle meningeal artery lying below the pterion, lying below the pterion. Subdural hematoma, it is going to be the veins. It is going to be the veins. नो 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 नो, बिल्कुल उल्टा नहीं है, बिल्कुल नहीं, नो नो नो. फॉर अ वेरी स्मॉल, for a very small extradural hematoma, you can do burr hole. You can do burr hole. Fine. For a very, very small extradural hematoma. No, never, never, never. Here we have to do burr hole. Right? So answer is bilateral chronic subdural hematomas. Bilateral chronic subdural hematomas. Okay, so these three questions are of GCS and they are taken directly from the website of the Glasgow Medical College. Directly from the website of Glasgow Medical College. Though I've changed the languages just to avoid the copyright shift, but certainly they are directly. Srikanji will do it quickly. I told you I got a target of around 2 hours and I'll finish by around 9 o'clock. You don't have to worry. Many questions are there, but I'll finish by 9 o'clock. I've left my watch aside. So 24-year-old male victim of roadside accident was reported as unconscious by the caller to the ambulance service paramedics. When attended, he opens his eyes and resists the attempts to pass a nasal airway, cursing the paramedics. He is unsure about his whereabouts. Fine. So let's see. So first of all, EVM. He kept his eyes closed. Listen to what is there in the question. He was keeping his eyes closed. So you might want to give him 1 mark. But when the paramedics wanted to pass a nasal airway, there was some pain. So this patient is opening eyes to pain. So I score would be 2. I score would be 2. Right? Now, resist the attempt to pass a nasal airway. Resist the attempt to pass a nasal airway. That means this patient can localize pain. This patient can localize pain. 6. Now, he is unsure about his whereabouts. But you see, he is cursing the paramedics. जो paramedics हैं उनको गालियां निकाल रहा. But he is confused. So you see, this patient is confused. This patient is confused. So verbal score would be 4. Verbal score would be 4. Verbal score would be 4. So total score is like this. EVM 2, 4, 5. So the answer here is 11. Answer here is 11. Answer here is 11. E2, V4. No, he's just localizing the pain. He's not obeying your commands. He's just localizing the pain. Localizing the pain. He's just localizing the pain. Yes. So this question, what you see on your screen, was given as, as a self-help question. So I believe this is extremely important, the point which they are trying to convey here. 41-year-old man called Danny, I was going to write Johnny, so is admitted to the emergency department on Sunday, 1st of January 2014 after being involved in a fist fight. When you ask the patient to tell you his name, where he is, and what the date is, he answers Denny, hospital, and December. Denny, hospital, and December. So you see here, if your patient is oriented, you are going to give V5. So the explanation which they gave on their website, that if your patient is confused for whatever reason, if your patient is confused for whatever reason, you cannot give him V5. You have to give him V4. You have to give him V4. You have to give him V4. This is the explanation written on the website of Glasgow Medical College. Fine. So you have to give this patient V4. You see, patient is already in January and he's saying I'm in December. For whatever reason, he may be disoriented. If he's not giving you the right answer, no leniency. You have to give your patient V4. You have to give your patient V4. Motor component of trauma victim is being assessed. Again, this question is from GCS website. He is unable to obey commands but bends his elbow when fingernail bed is stimulated. So you see here, he is unable to obey commands. Unable to obey commands. So maybe you can give him M5. You can give him M5. But you see, what will you do after you stimulate the nasal bed? You'll have to make sure, listen to me carefully. You will have to make sure that he raises the hand above clavicle. If you have to give your patient M5, you have to make sure कि patient अपना हाथ ऊपर लेके जाए clavicle से. You have to make sure that patient raises his hand above clavicle. Above clavicle. Above clavicle. So this is the logical next step. Sternal rub should not be done. Sternal rub should not be done. No, let me just write it up for you. So motor, if your patient obeys command, it is going to be 6. If your patient can localize pain, it is going to be 5. Now, this has to be only 2 things. Only 2 things are allowed. Only these 2 things are allowed. Flexion, it would be 4. Abnormal flexion, it would be 3. Extension, it would be 2. No response, it would be 1. No response, it would be 1. No response, it would be 1. right? So if you have to give 5, patient must raise hand above clavicle, above clavicle. So the logical next step there is trapezius pinch, Even for normal flexion, hand must cross midline like this. Hand must cross midline. Hands must cross midline. So trapezius pinch is the logical next step. 32-year-old man arrives at emergency department with an exquisitely painful and woody feeling penile erection of 18-hour duration. You see, anything more than 4 hours, this would be called as priapism. Yes, Dr. Apeksha, you're right. Aspiration of blood, it is the preferred treatment there. So this is the preferred emergency treatment. Irrigation of corpora with pipervirin, no. Remember, pipervirin is used to cause erections. Fine. Now, this can be done. So C and D, they are type of shunt. So this irrigation of corpora cavernosa with pipervirin is certainly not the right treatment. You can do aspiration of blood as an emergency measure. Now the things will go rapidly. Now. Identify the device. So you see, this is a Salem double lumen pump catheter. This certainly is not a Foley's catheter, buddy. 1 and 2. Certainly is not a double lumen. Salem. Okay, what is this? Again, you see, this is a type of drain. What kind of drain is this? Penrose drain for wounds. I'll complete, don't worry. Yes. What is this? See, Jackson will be having a suction pump. Now this you see is a double J stent. Which of the nerves can be damaged in the following surgical position? So you see, this position is lithotomy, and long positioning in this position can damage saphenous nerve, can damage obturator nerve. So the answer is both of the above, both of the above, both of the above. A 50-year-old woman presents to surgery OPD with complaint of severe retrosternal chest pain after meals associated with a bitter taste in her mouth. She has no difficulty or pain when swallowing. That means she has no dysphagia. Which of the following would be most useful in establishing the cause of her symptoms? So you see, she is just suffering from GERD. She is just suffering from GERD. So answer is 24-hour pH monitoring. So based on that, we get D Mister score, D Mister score. So if D Mister score is more than 14.7, more than 14.7, we say that our patient is suffering from GERD. Now, remember, what is the first investigation in case of GERD? First investigation would be endoscopy. First investigation would be endoscopy. First investigation would be endoscopy. A 35-year-old female undergoing treatment for primary infertility presents with history of right-sided lower abdominal pain associated with nausea. She has had no other genitourinary symptom. History taking reveals that she has had several similar but less severe episodes. Her pregnancy test was found to be negative. Why it is not appendicitis? Remember, what do you get to see in appendicitis? In appendicitis, you get to see Murphy triad. Murphy triad. Remember, what is there in Murphy triad? Pain, nausea, fever. Pain, nausea, fever. Now, remember what is so special about this pain, that this pain is migratory pain. This pain is migratory pain. You don't get to see migratory pain over here. Also, appendicitis is more common in men. Which type of men? Young men, 10 to 30 years of age. So neither the age is matching nor the gender is matching. So this could not be acute appendicitis. This could not be acute ectopic pregnancy because the UPT is negative. UPT is negative. This could not be pelvic inflammatory disease because she has no genitourinary symptoms. No genitourinary symptoms. So this is the only diagnosis that remains. This is the only diagnosis that remains. Yes, Dr. Ganesh Rai. That is why I'm saying that this is not acute appendicitis. This is not acute appendicitis. Besides, what is the catchword over here? What is the catchword over here? Fine. She has had similar but less severe episodes in the past. Similar but less severe episode in the past. So that itself indicates that she is actually suffering from torsion. Torsion of the ovary. 24-year-old man is brought to emergency department with history of fall from height. He was diagnosed to be suffering from wedge collapse of lumbar vertebra. Foley's catheterization was done as a part of management. The color code of Foley's catheter. Yes, I'll wait for the answer there. Akshay Panchal ji, ye kya tha, bro? So you see, the logic is Green goes everywhere. Green goes everywhere. So green is number 14. Green is number 14. Green is number 14. See here. You see green, this green, number 14. Number 14. Now you see yellow and red. Red and yellow. That is for removing blood clots. That is for removing blood clots. That is for removing blood clots. Red and yellow is for removing blood clots. Is for removing blood clots. Yes, 38-year-old female presented to surgery OPD with complaint of fresh rectal bleeding and intermittent rectal pain. On examination, non-tender, non-reducible lump is seen emerging from the rectum. What is this patient suffering from, first of all? Anyone? No, not IV cannula. We are talking about the Foley's catheter. So what is this patient suffering from? So you see, this patient is suffering from third degree hemorrhoids. Third degree hemorrhoid. You see, first degree hemorrhoid. What is the treatment? Sclerotherapy. Second degree hemorrhoid, what is the treatment? Banding. Third and fourth degree, the treatment is hemorrhoidectomy. Hemorrhoidectomy. Now, since it is a non-reducible lump, so this is going to be fourth degree hemorrhoids. Fourth degree hemorrhoids. Fine. So the treatment would be hemorrhoidectomy. Hemorrhoidectomy. Anal dilatation is the treatment for fissure, anal fissure. Banding is the treatment for second degree hemorrhoid. Sclerotherapy is the treatment for first degree hemorrhoids. First degree hemorrhoids. A 68-year-old man presents to surgery OPD with a 3-month history of lump in the left groin. On examination, a reducible compressible lump not extending up to scrotum is noticed above the inguinal ligament. Cuff impulse was noticed. Which of the following is the most likely diagnosis? No. So you see, what is the difference between indirect and direct hernia? Indirect hernia is common in young. Direct hernia is common in old. Direct hernia is common in old. Indirect is pyriform in shape. This is globular in shape. Globular in shape. Fine. Indirect and direct hernia. Main difference is that of age. Main difference is that of age. So this patient of yours is definitely suffering from direct inguinal hernia. Remember, femoral hernia will present below and lateral to pubic tubercle. Gluteal hernia is extremely rare, and indirect hernia will occur in the young. Indirect hernia will occur in the young. Will occur in the young. Occur in the young. So you have to identify the type of repair. I've zoomed it up so that you can see which type of repair is being performed. Which type of repair is being performed? Yes, strangulation is very common. ओके अतुल्य जी, एक मिनट आएंगे जरा, मुझे जो उस स्क्रीन पे दिखाई दे रहा है बच्चों को वो दिखाई दे रहा होगा या ये दिखाई दे रहा होगा? नहीं, मेरे आईपैड पे जो है थोड़ा फास्ट चल रहा है, उस पर थोड़ा स्लो चल रहा है, एज इफ थोड़ा लैग है। अच्छा, बच्चों को क्या दिख रहा होगा, ये क्या वो बच्चों को ये दिख रहा होगा ना? अच्छा ओके, फिर तो बहुत लैग नहीं है। ओके 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 ओके, no, you see here, so in the case of inguinal hernia, in the case of inguinal hernia in children, the preferred treatment is herniotomy. Preferred treatment is herniotomy. For adults, the preferred treatment is hernioplasty. What is the name of hernioplasty? Lichtenstein operation. Lichtenstein operation. We place a mesh. We place a mesh. Fine. Now, if it is a strangulated hernia, strangulated hernia means lumen of intestine plus blood supply both are blocked, plus blood supply both are blocked. This is strangulated hernia. In this case, the treatment of choice is Bassini operation, which is a herniorrhaphy, which is a herniorrhaphy. But what we are doing in this, in this screen, which you can see on your screen, is Schulde's operation. What is Schulde's operation? Schulde's operation is double breasting of fascia transversalis. See double breasting. You can see we have formed two layers like this. Two layers like this. Like this. Like this. So it's a strong one. Two layers. Overlapping, yes. So you can see there is overlap. You can see there is overlap. Double breasting. Fine. So option is Schulde's repair. Schulde's repair. Now, they all, 1, 2, 3, what are they? They are a type of herniorrhaphy. Herniorrhaphy means without mesh. Hernioplasty. Lichtenstein repair with mesh. Lichtenstein repair with mesh. Right? Lichtenstein repair is with mesh. So Bassini repair, no. Bassini repair, we don't do double breasting. Bassini repair, we don't do double breasting. Marcy repair, we just close the ring. We just close the ring like this in Marcy repair. We just close the ring. So this is Schulde's repair. Whenever you see anything like this, so this is going to be Schulde's repair. Schulde's repair. Whenever you see overlapping, naturally this is going to be Schulde's repair. Okay, important there. 55-year-old school teacher present to surgery OPD with a complaint of groin swelling. Upon clinical examination, patient is noticed to be suffering from hernia. According to European Hernia Society classification, the hernia is marked as RL3. RL3. No, Bassini. No, not in femoral hernia. Not in femoral hernia. So while many of you are looking for the option, let me write the surgeries for femoral hernia. Henry operation, Lockwood operation, Lothisan operation. So these are the surgeries for femoral hernia. These are the surgeries for femoral hernia. Surgeries for femoral hernia. So you see this. P is for primary hernia, means fresh hernia, no history. R is for recurrent hernia. R is for recurrent hernia. Recurrent hernia. You see L. L is for indirect hernia. M is for direct hernia. F is for femoral hernia. F is for femoral hernia. F is for femoral hernia. Fine. So your patient is RL3. So that means your patient has a recurrent hernia and it is an indirect hernia. Indirect hernia. And the deep ring is very wide. 2 fingers can go through. 2 fingers can go through. I took this particular image from Subiston only. Okay. 38-year-old shopkeeper, chronic smoker. This is the first keyword. Diagnosed to be suffering from Berger disease. Remember Berger disease, 20 to 40-year-old males, smokers, and small sized arteries. Small sized arteries. He was advised lumbar sympathectomy. Surgery went uneventful. Patient complains of groin pain, paresthesia, burning sensation from lower abdomen to the medial aspect of thigh. Basically, this is a question of anatomy. Not more a question of surgery, but more a question of anatomy. Fine. So, which nerve you think is injured? This is the genitofemoral nerve. This is the genitofemoral nerve which is injured. Genitofemoral nerve which is injured. So if the L1 ganglion is cut on both sides, remember what will your patient develop? Your patient develops retrograde ejaculation. Remember that P and S mnemonic. P for point. Point up means erection. S for shoot. Shoot means ejaculation. P is parasympathetic. S is sympathetic. So if you cut the sympathetic nervous system, your patient will not be able to ejaculate normally. Right? So L1 ganglion cut on both sides will cause retrograde ejaculation. Iliohypogastric nerve, totally different nerve distribution. Totally different nerve distribution. Slightly up over the bladder, basically. Iliohypogastric over the bladder. Okay. Lateral femoral cutaneous nerve. This is not the right answer there. 46-year-old. See, this is a difficult question. So I've deliberately kept this question there so that you are prepared for bloopers. They can ask you one tough question. So my kind of idea, my humble request is to you guys, whenever you see any tough question in the exam, don't panic. Don't panic. If you know the answer a bit, mark that answer. If you don't know the answer, If you think that I have not read this question anywhere, I have not seen this topic anywhere, just skip and focus on the next question, right? That is the idea of sharing this video. Yes. So you see here, they are going to ask you about the SEEP classification. SEEP classification. So this is what SEEP classification is. This is what SEEP classification is. Your patient, reticular veins are seen. What are reticular veins? 1 to 3 mm in diameter. 1 to 3 mm in diameter. Fine. So here you see very fine spider veins, reticular veins are seen, right? So this is going to be C1. This is going to be C1, right? So this is going to be the right answer. I believe that if you have some little time, energy and patience, and if you have read this SEEP classification once, at least once, if you have not read it, don't do it now. Because, this is not the time to grasp a new information. If you have read it once, do it. Fine. They can ask you any silly question over there. So they are known for asking silly questions there. Now you see here. So please, let's quickly read this. During ongoing COVID pandemic, obese 41-year-old alcoholic male suffered a bout of pancreatitis and he had to be hospitalized. He, however, tested negative for COVID-19 on 2 different occasions. So now he's free of COVID. Upon admission, his condition gradually improved and was shifted out of ICU after 2 days. Later, while being nursed in the general ward, he complained of pain in the calf, which precluded his ambulation. That means he cannot move properly now. On examination, both his lower limbs were found to be edematous and mild tenderness was also noticed in his calf muscle. Which of the following may act as screening investigation? See, duplex B scan is the investigation of choice and that is an expensive investigation. So D-dimer assay is the screening investigation, I'm sure you know which disease is being talked about. Deep vein thrombosis. Deep vein thrombosis. Remember, what is the earliest sign? Earliest sign is tenderness. What is the most consistent sign? This is going to be edema. Edema is the most consistent sign. You please tell me, okay, I will choose a different pen color. What is going to be the drug of choice? Drug of choice is low molecular weight heparin. That has to be given for 5 days. Then we will shift the patient to warfarin. That has to be given for 3 months in the first instance. 3 months in the first instance. And if it is a recurrent disease, we'll have to continue it lifelong. We'll have to continue for the treatment lifelong. Right? Okay. A 64-year-old man presented with a 6-month history of epigastric pain, weight loss, and nausea. In the previous 3 months, he had lost 10 kgs. Your patient is having cancer cachexia. Upper endoscopy revealed an adenocarcinoma of gastric corpus. Corpus means the body. Deliberately, I've kept technical words over here so that you are not terrified in the examination upon listening to a technical word. CT scan of the abdomen showed liver metastasis, metastatic adenocarcinoma, non-tender, firm, fixed neck swelling. It was later found as an enlarged lymph node. Yes, please tell me, what is this? But don't do this. Especially those who have read with me. Remember, we studied all the different type of lymph nodes. So if this is a sternocleidomastoid muscle, remember here it was level 6. It was level 5 in the posterior triangle. Posterior triangle. And here 2, 3, 4. 2 is upper jugular. 3 is middle jugular and 4 is lower jugular. And remember, what is this? This is a question of anatomy. You see, Virchow node. Virchow node is group 4 node. Is group 4 node. Group 4 node. Group 4 node. Virchow node is group 4 node. Supraclavicular is group 4. Group 4. 5 and 5A, 5B. They are the nodes which are seen in posterior triangle. Posterior triangle. Just give me a minute. You know, there is often confusion over here. So what is this? Trozier sign. Trozier sign is enlarged supraclavicular lymph node. Trozier sign. Trozier sign is, remember, carpopedal spasm. Where do we get to see? We get to see this in hypocalcemia. Fine. Trozier syndrome. Trozier syndrome is migratory superficial thrombophlebitis. Thrombophlebitis. Right? Now, our patient is showing Trozier sign, that is enlarged supraclavicular lymph node. Now, this is level 4 lymph node and this is enlarged in GI, gastrointestinal and pancreatic malignancies. Pancreatic malignancies. This is enlarged in both malignancies. Yes. Before being used on a patient, fresh frozen plasma should be thawed. So thawed again is a slightly technical word that literally means melting. In water bath is just, a bucket full of water between 30 to 37 degrees centigrade. You see, how do we store the fresh frozen plasma? We store it at minus 18 degrees centigrade or minus 42 degrees centigrade. Fine. So here we can store it for 2 years. Here we can store it for 1 year. We need to melt it. Okay. Why don't we keep the temperature higher than 37 degrees centigrade? Because the level of clotting factor, especially clotting factor number 5 and 8, their level will diminish extremely rapidly. Level 5 and level 8, they are heat labile factors. That is the precise reason that we have to store plasma at minus 42 degrees centigrade. Minus 42 degree centigrade. A 56-year-old woman, a chronic smoker, is referred from orthopedics OPD with 6-month history of pain left shoulder radiating to arm. Or we have not started orthopedics. This is a surgery question only. Physical examination is unremarkable, including range of motion of her left shoulder and chest auscultation. Everything is normal in the chest. Everything is normal in the shoulder. Family history of diabetes, lung cancer and breast cancer. So, X-ray of cervical spine, normal. Shoulder joint, normal. Okay. Now, on chest X-ray, there is small opacity in the left apex. So, you see this word. because we don't read lungs anywhere in the surgery. So if you get to see any small opacity plus shoulder pain, this is going to be the diagnosis. Try this whenever you are in practice. If your patient says, I'm having shoulder pain, you get the x-ray done. There is a suspicious shadow. This is only and only going to be non-small cell carcinoma. Non-small cell carcinoma. Non-small cell carcinoma. This is a typical history. That's why I've kept this question. 42-year-old morbidly obese computer engineer presents to surgery OPD. All his effort to manage his obesity failed, including dietary therapy, exercise, and even drug therapy. Remember which drugs we use. So we use Orlistat, we use sibutramine, we use amphetamines. When do we use amphetamines? When the basal index is more than 30. Right? BMI more than 30, we use this. Attending doctor advises him to undergo Roux-en-Y gastric bypass surgery. Before undergoing the procedure, to obtain his informed consent, he needs detailing about. Achha, there was a question that in informed consent, remember, in the informed consent, we only tell about complications which have more than 1% chance of occurring in the informed consent. Right? Now, this patient, morbidly obese, he wants to undergo surgery. So main disadvantages of this condition is dumping syndrome. Main disadvantage of bariatric surgery here is dumping syndrome. Dumping syndrome. Right? Okay. Elderly man is stuck with a heavy object, develops an open wound on his scalp, suspected fracture of the skull bone. The fracture was later confirmed. Dura mater was found to be intact. So you see, there is a wound plus there is a fracture. So this is a compound fracture. Depressed fracture would have damaged dura mater. Complicated fracture means there is some other organ injury also. Dumping syndrome, yes, I'll do. Stellate fracture. Stellate fracture is generally seen in osteoporotic bones. Fine. And generally, stellate fracture is seen in the bone which don't have periosteum. Like patella. Don't worry, Dr. Teja. Let me finish the question and then I will explain dumping syndrome. That's my promise. But let's finish the questions first because your time is extremely precious. Let's finish the question. We are left with very little question. Let's finish them. Then I'll explain the topic. Then I'll take the queries. 55-year-old, otherwise healthy male presented to surgical emergency with complaint of acute retention of urine. He was catheterized. Procedure went uneventful. In due course, ultrasound was performed which revealed an enlarged prostate. Management of this case would involve. So you see, acute retention is an indication of surgery. Acute retention is an indication of surgery. Acute retention is an indication of surgery. What is the most common indication of surgery? Most common indication of surgery is no improvement in prostatism. No improvement in prostatism. So the surgery is TURP. Since your patient has an acute retention, that is also an important indication of surgery. Best time to do orchidopexy in a case of undescended testis. Immediately after birth? No. Why? Because most of the undescended testis will descend by 2 to 3 months of age. Too late, there would also have occurred hypoplasia. Adolescent, not done, extremely high chances of cancer. Extremely high chances of cancer if we wait this long. What is the correct time? 6 months to 12 months. Somewhere between 6 months to 12 months. If you have to choose one, go for 6 months. If you have to choose one, go for 6 months. 66-year-old female presents to emergency department with a 6-hour history of abdominal pain, bloating, vomiting, conscious, oriented. Local examination reveals a distended abdomen, tympanic to percussion. Auscultation reveals intermittent high-pitched sound. That means she is having intestinal obstruction. She is having intestinal obstruction. Abdominal X-ray shows air in the biliary tree. That means pneumobilia. Pneumobilia. Fine. So you see pneumobilia plus intestinal obstruction. This is seen in gallstone ileus. So if we add ectopic gallstone, what does that become? That becomes Rigler's triad. That becomes Rigler's triad. So our patient is suffering from gallstone ileus. Our patient is suffering from gallstone ileus, right? Remember, what is the treatment of gallstone ileus? First, we take care of intestinal obstruction. Then only we'll take care of the gallbladder. Then only we will perform cholecystectomy. So pneumobilia, in our practice, in our exam, they are not going to ask beyond gallstone ileus. There could be 100 causes of pneumobilia, but if in our exam they are going to ask pneumobilia, this is going to be gallstone ileus only. 33-year-old football player sustains anterior shoulder dislocation. Remember, this is the most common type of dislocation. while engaging an opponent. Radiographs of the patient determined the patient to have a small hill sac lesion. Hill sac lesion is the depression on humerus head. H for hill sac, H for humerus. Which of the following radiograph is best suited for visualizing this lesion? This is not important, this is not important, this is not important, but this is extremely important. Remember, I did mention it in the class. I did share a PPT which shows this view. Striker notch view. Striker notch view for shoulder dislocation. 50-year-old taxi driver sustains a posterior dislocation of left hip. So, in case of hip, most common dislocation is posterior. This is usually sustained in car injuries. What is the attitude? Fadder, flexion, adduction, and internal rotation. And usually it is associated with cruciate ligament injury. Cruciate ligament injury. Cruciate ligament injury. Right? So this is going to be the answer. Patient before being discharged from the hospital should be told to avoid. Remember the developmental dysplasia of hip topic. Now, you see, it is the most common congenital disorder around the world, but not in India. Why? Because here the mother holds the baby like this. Fine. So legs of the baby, they are wide apart. Legs of the baby, they are wide apart. So here also, we'll ask the patient to keep his legs wide apart. If he crosses his legs like this, yeah, I can see. Then the dislocation will occur again. Dislocation will occur again. Fine. So he has to avoid this, this, this. So answer is D. Answer is D. Questions are over. These are the bonus extra questions. And then I'll explain that dumping syndrome. 10 minutes more. Please answer what is this. That is for rapid fire question. Please answer what is this. Extradural hematoma. Biconvex. Please answer what is this. So this is also acute extradural hematoma. Biconvex. Please answer what is this. Please answer what is this. Rapid fire. No, this is not EDH. This is just a scalp hematoma. This is just a scalp hematoma. Scalp hematoma. Again, this is also a scalp hematoma. Make no mistake while answering your, in the exam. Here you can make mistake, but don't do it in exam. Yes, what is this? What is this? So you see, there is no fracture. This part you see is concave. So this is a subdural hematoma. Subdural hematoma. Subdural hematoma. Why? Because it is elongated. This is not restricted by suture line. Yes, it is banana shaped. Yes, tell me, what is there? Again, you can see scalp hematoma, you can see a fracture, you can see a fracture, you can see slight midline shift. Please watch this image closely and tell me what else do you see over here? What else do you see over here? I really want any one of you to please answer. What else do you see over here? Okay. Do you see any gyri or sulci? Arey wow, Mr. Android. I'm so glad you gave the right answer. Cerebral edema is what you see over here. Cerebral edema. Cerebral edema. So you don't see any gyri or sulci. That is why this image is characteristically showing cerebral edema. What is this? Again, you see, this is acute subdural hematoma. Yes, now tell me what is this? 38-year-old male victim of high-speed motor vehicle accident. See the image. If you want me to zoom them up, I will. Oh my God. Dr. Bobby, Dr. Manpriya, and Mr. Android, I'm so glad you gave the right answer. This is what you get to see in the diffuse axonal injury. Remember, in the diffuse axonal injury, the investigation of choice is MRI. For all other brain injuries, the investigation of choice is non-contrast CT. But here, the investigation of choice is MRI. Yes. What do you get to see over here? What do you get to see over here? बड़ी नंबर तो देखो ना, एक भी क्वेश्चन सही हो गया तो एक नंबर हमें मिल गया बस. So this is also diffuse axonal injury. Diffuse axonal injury. You don't see the injury directly, but you see the edema. And the black colored thing which you can see between the circle is edema. Now, these are copied questions, but this is an extremely important point. I deliberately kept this question because when I took this, 2 or 3 batches I took here, and almost all the students gave wrong answer in this. Except my boy Rahul and Yogesh. लोगों को खुश रखना पड़ता है, वरना बोलो तबाही मचा देंगे. 21-year-old male presented to emergency room with complaint of severe pain right testis radiating to lower abdomen. On examination, right testis was hanging. It was like this. Right testis was hanging at a lower level. Yes, so what is your patient suffering from, first of all? Is your patient suffering from torsion? There is pain in right testis, and if the testis with pain is hanging low, that testis is having infection. If the testis is hanging high, that testis has torsion. That testis has torsion. So this patient has epididymorchitis. Epididymorchitis. Right? Now you see this patient, again excruciating pain, right testis. Now the medical officer consider it to be torsion testis. How will the diagnosis be established? In case of torsion, the testis would be like this. Torsion. Epididymoorchitis, testes will be hanging low. Torsion will be hanging high. So this is wrong. Affected testes will lie at level higher than normal testes. This is correct. But any attempt to raise it will not reduce pain. It will increase pain. Cremasteric reflex is absent is the right answer. Positive history of unsafe sexual contact is seen in epididymoorchitis. Seen in epididymoorchitis. So C is the right answer. I've kept only those questions which many of the students marked as wrong. Questions are over again. I'm just giving the bonus extra questions. Fine. Now, so you see this condition, ectopia vesicae, multiple option, is not more common in females. Is it more common in males? And if it is present in male, epispadias will be present. Fine. The pubic bones will be far apart from each other. Patient usually dies of renal failure. Another complication is adenocarcinoma. So D is the right answer. All are correct. All are correct. Oh, I'm sorry. D is not the right answer. B is the right answer. Second, third, and fourth are correct. A is wrong. A is wrong. B is the right answer. False about the picture shown below. So what type of stone is this? Staghorn calculi, triple phosphate stone, calcium, magnesium, ammonium, associated with Proteus infection. So that is the most common organism seen in acidic urine. This is definitely wrong, because this is seen in alkaline urine. True white stones. Fine. So you have to check the false. Open surgery is not preferred. It can be done. It can be done. It can be done. Fine. So only C seems to be the false one. Seems to be the false one, because it is clearly seen in alkaline urine, and the infection most commonly is caused by Proteus infection. It can be done, but even this can be managed by ESWL or PCNL. Identify the type of stones. What do you get to see over here? You get to see dumbbell shaped hourglass crystals. Hourglass crystals. The most common type of stones. Most common type of stones. 42-year-old railway station announcement clerk presented to surgical OPD with complaints of difficulty in swallowing both solids and liquids. See, it could be achalasia, it could be Zenker's diverticulum. How to settle the diagnosis? In both, most common clinical feature is dysphagia. How to settle? With the help of barium swallow. With the help of barium swallow. So this will settle. This will settle. Likely age of the patient. Let me zoom it up so that you can see. You have to tell me the likely age, the most common age of this patient. And here I'm not giving you any option. That's just a spotter. It is Zenker, but you have to tell me the age. Zenker diverticulum, young female, totally opposite. Common in elderly. Common age is around 60 years. 60 years. It's not common in young. No. Correct yourself. Please correct your notes. It's common in elderly. Again, that is also Zenker's diverticulum. Remember, it is false diverticulum. Remember, it is most common diverticulum. Most common diverticulum. Yes. What type of esophagus is this? No, I believe it's more than 60 years only. I'm not aware of that bimodal age distribution. Wow, Dr. Ajit, I'm so glad that you gave the right answer. Shaggy esophagus. Shaggy esophagus, typically seen in Candida. So this is the endoscopic appearance. Rat tail is seen in ecclesia. Identify this device. So this is Celestin tube. Celestin tube. We use it for palliation. We use it just for palliation. Celestin tube. Now these are the different type of tube. Atkinson tube, Moose-Barbin tube, Sottar tube, right? Now, I've kept all the ink markings intact and will seek permission from sir if we can share this. Fine. Now, somebody just wanted, now I'm ready to take your queries there. Somebody just wanted to understand about the dumping syndrome. Understand about the dumping syndrome. See, this is the normal stomach physiology. There is pyloric sphincter, which will open only after a while. Only after a while. But you see here, let me take a picture here. So you see, this is what we do in the Roux-en-Y gastric bypass. So you see what will happen. The food will directly enter into the jejunum, and you see this food will be concentrated. When the food enters normally, it is diluted by bile. But here, the concentrated food will enter the jejunum. And there, it causes osmotic changes. So it will draw the water out of jejunum wall. It will draw the water out of jejunum wall. Fine. Now, where will the water come from? From the blood only. So, your patient experiences hypovolemia. That is called as dumping syndrome. Now, this will present 15 to 20 minutes after meals. So this is called as early dumping. Early dumping. Now, 2 to 3 hours after meals. 2 to 3 hours after meals. Fine. What we can do, 2 to 3 hours after meal, what will happen? There will be sudden rush of dextrose because it has been absorbed from the concentrated food. So there will be hyperglycemia. Now then, hyperglycemia will cause insulin level to rise. Then there will be hypoglycemia. Then there will be hypoglycemia. Ritesh ji. So this is called as late dumping. Late dumping. Right. So we'll share the PDF. We'll share the PDF. Fine. And if you have any further queries, you can send it. And then I'll be. No, I didn't ask that. No, I didn't ask that. See, intercostal tube will be inserted in the fifth intercostal space, mid-axillary line in both adults and children. So this has to be there in the triangle of safety, but the needle will be there in the second intercostal space in children and fifth intercostal space in adults. So needle has different position, tube will go in the same. Yes. See, prolapse can be seen in small children, prolapse can be seen in elderly. Prolapse is 6 times more common in females. 6 times more common in females. Six times more common in females. Ritesh ji, can we end the class? बच्चे अपना पढ़ लेंगे अभी, है ना? Right. So on the Telegram group, please do send your queries. See, this second intercostal space, it has to be in mid clavicular line. Mid clavicular line. ऐसा नहीं है यार. I'm always available for you guys. Everyone knows. कल रात को 2:30-3 बजे के आसपास बच्चों के बैठ के आंसर दिए थे, तो उस समय तो माहौल में नहीं था ना. राइट. ऑल द बेस्ट. सब लोग अच्छे से पढ़ो, बहुत जोरदार तरीके से पढ़ो. वी रियली वांट कि आप लोग सब 200 से ऊपर नंबर लेकर आओ. फाइन. Rat tail and bird beak, they are same. Rat tail filling defect is seen as cancer. Fine, that is the only difference there. Sir. Sir. Done. Ji sir. Ashish sir is there.
Hello to everyone. I hope you all are enjoying the session. थोड़ा ऊपर कर दे. क्या बात है sir. So yes, I'm really grateful to our beloved Nitin sir, ठीक है, and he's like भाई हैं बिल्कुल, and he's been कहते हैं ना pillar of strength for us from the beginning when we had that COVID time and everything closed. He was the first faculty to take sessions. याद है सर आपको सर्जरी? तो yes, we started that online session and sir took session. Since that day he is with us and he's always been there for you people, giving his brilliant insight into the एंड ये सारे एग्जाम क्वेश्चन है. अगर ये नहीं आता, ट्रायंगल ऑफ सेफ्टी फिफ्थ है, सेकंड है एस्पिरेशन की, इसमें क्या, देन यू आर गोइंग टू बी ना लूजिंग मार्क्स. ओके, सो दिस इज आई एम वेरी मच श्योर विल कवर एट लीस्ट सर 20+ बोल दूँ.
डेफिनेटली
20+ MCQ. ज़्यादा आएंगे पर फिर भी 20+. तो अगर 20+ MCQ कर लिए, कितने रहेंगे सर एग्जाम में? 15 ना 14. तो अगर आपने 14 डेज हैं कर लिए तो 280+ हो रहा है सर, तो ज़्यादा हो गया. So if you can cover 280+, I think it's a very wonderful method. So 14 days into 14 दिन में बिल्कुल आप तो 14 ही कर दोगे सब चीज़ों का, है ना. So that will be a great achievement. So yesterday was a awesome session. by Dr. Shrikant. Today is also awesome. Tomorrow, Harmeek ma'am will be taking. So we are trying to cover as much as possible rather than just doing some कहते हैं ना important MCQs. We are discussing theory also so that you are able to solve more and more question. Okay. So anything you need, everything PDF etc. will be given in the group. And if any doubt regarding this, and do give some blessing regarding our NLC as an institute. Please ask your junior friends कि there is a very good institute where good faculties teach and they are all qualified MD, MS, proper with experience of 10 years plus. So this is the number for any doubt and queries. Okay, 7770003686. Okay, so we'll be starting admissions from 5th of June. So I wish lots of people come and we are able to what help you as much as possible. Yes, chalo, thank you very much to everyone. Leela, Apeksha, Satabdi, Divya, they're all our students. Chalo. So if anything, you just message, we will, yes, have more and more session. Yes, so 5th say we are having live sessions, live classes. So 5th June is online classes and 20th June is offline. So they'll be there and I want all of you to pass the exam and refer your juniors and friends. Okay, आप लोग मत आना, आप लोग पास हो जाना. That is the only request we are having from you. Okay, don't take any distraction, don't ask from anyone. जोसना को मेरी तरफ से क्या भर भर के chocolates, she's saying 2000 admissions. ठीक है, I'll personally find you your address and send you a group, a bunch of chocolate and जो भी bouquet flowers. ठीक है, चलो. So really wish tomorrow OBG, 2 days you will have OBG session. Okay, so I think सर एक मैसेज दे दो बच्चों को लास्ट क्या करना है.
सर मैं तो उनको बार बार एक ही रिक्वेस्ट कर रहा हूँ कि बस अब पढ़ते रहो, दबा दबा के जो भी आपका क्वेरी है मुझे प्लीज भेजते रहिए ग्रुप पे. I'll be active there, I'll keep on
exam will be active on the telegram group. तो बस वही करते रहना
जोर से. बस 200 प्लस नंबर ले आओ. बाद में 4 तरीके बस सब हमारे ऊपर. मैंने बच्चों को इनवाइट किया सर अपने यहाँ पार्टी.
वाह वाह, बिल्कुल सर बोल रहे हैं तो बुआ के लिए भी कह रहे हैं कई लोग, वो भी कर लेंगे. सर के साथ में. ठीक है, मैम आए, हम सब लोग आए एंड विल गो टू गोवा एंड एंजॉय. सब मजे करेंगे गोवा में.
ये ठीक.
चलो, सो विल फिनिश द सेशन. ओके, ठीक है सर, आपका हो गया.
हाँ सर,
ठीक है, विल फिनिश. हाँ,
आई विल पास. एक बार बोल दो प्लीज.
सब लोग टाइप कर दो चैट बॉक्स में, आई विल पास, आई विल पास, आई विल पास, आई विल पास. ओके, टाइप करो भाई, आई विल पास लिखो भाई. हाउ मेनी एमसीक्यूज डू इन अ डे? अरे भाई एटलीस्ट 200 प्लस. डू 200 प्लस एमसीक्यूज पर डे, 200 प्लस. एंड टिप्स फॉर सर्जरी हमने बता ही दिया आपको. ठीक है सर, क्या होता है रीड ऑप्शंस?
सर मैं 2-3 पढ़ा. एक तो जीआईटी वाली इमेजेस सर, जीआईटी वाली इमेजेस, थायराइड, ब्रेस्ट, फाइन. और जो ट्रॉमा में जो ग्लासगो कोमा स्केल में जो चेंजेस मैंने आज जो अलग से क्वेश्चन बताए थे.
वेरी इंपॉर्टेंट. प्लीज डू इट. चलो, विल टेक लीव. बाय बाय, टेक केयर. ठीक है, वंस अगेन सर, थैंक यू.
थैंक्स.
कमाल कर दिया आपने. हाँ, कर दिया.